good morning, everybody. I would like first to thank Dr. Baumann for the invitation and also to the organizing committee. Today, I will talk about the accuracy of the FDG PET-CT scan in the primary staging of biological high-risk prostate cancer defined by Gleason more than 7 before local therapies. As you probably all know, prostate cancer has been classically imaged by computerized CT scan and also by bone scan. And in the last maybe 10 years, the MRI has been shown to be very accurate in the staging of prostate cancer within the pelvis. The indication for staging prostate cancer is mainly in a high-risk patient. The AUA guidelines, the American Urological Association guidelines, states that every patient with a Gleason sum above 7 or a PSA above 20 should have both a bone scan and a CT scan. The NCCN guidelines suggest that patient with Gleason sum above 7 or a PSA above 20 or T3 or T4 should have a bone scan, while a patient with clinical stages T3 or T4 or a predicted probability of having more than a probability of above 20% of having a lymph node metastasis should have a CT scan. However, the goal of this is to predict which patient will fail to local therapies. And the classical staging modalities are not that precise. So in the last maybe 20 years, molecular imaging cancer has been developed. And maybe molecular imaging, as you know, uses the alteration in the genes expressed in prostate cancer compared to normal cells, and the ability of a labeled molecule to image those alterations. And the labeled molecule is then incorporated into the cancer cells and can be detected by modalities such as the PET scan. And once it's fused with the CT scan, you can correlate the metabolism with the anatomy and show that there is, for instance, an increased metabolism into the lymph node. Probably the most utilized tracer in cancer is the glucose analog FDG. FDG is incorporated into the cells through transporters, which are called GLUT. And once FDG goes into the cells, it is phosphorylated by exokinase that traps FDG within the cell and then allows detection by a PET scan. FDG has been used and shown to be very effective to stage, restage, or predict response to therapies in many cancers, but this was not shown for prostate cancers. Early studies looking at the precision of FDG PET-CT in prostate cancers did not show that it was that useful. In 1996, a study involving 48 prostate cancer patients at different stage and grade did not show any difference in the FDG uptake between prostate cancer and BPH. Another study published in 1999 in patients that had radical prostatectomy and lymph node dissection after having an FDG PET did not show any detection by FDG of the lymph node metastasis. So the sensitivity for lymph node dissection in this very small series was 0%. After that, Song et al. Also published a not very convincing paper in which they were not able to image precisely a localized prostate cancer with FDG PET. The only utilization where they found it useful was in patients with castration-resistant prostate cancer that were progressing. They were able to image some patients with FDG PET-CT. However, there has been other papers that were more recently published that did show some maybe a role of FDG PET-CT in prostate cancer. One of them was published by Oyama, in which they looked at the accuracy of FDG PET for staging 28 untreated biopsy-proven prostate cancer compared to 5 BPH patients. And what they found is that there was a detection rate in the prostate in 65% of patients with prostate cancer and known in BPH. They also found that the detection rate for bone metastasis when compared to bone scan was 75%. And most interestingly, they found that the FDG uptake was higher in higher grade and metastatic tumor than in lower grade and localized prostate cancer. Another study published in 2003 also looking at high-risk patient having rising PSA after treatment. They staged them with FDG PET, and all these patients had a normal bone scan and equivocal CT scan. They then performed a surgical resection and found that 67 of the patients had lymph node metastasis by surgical resection. And in their series are very high-risk prostate cancer, more aggressive one, the sensitivity and specificity of the FDG PET for lymph node metastasis was respectively 75 and 100%. Another paper more recently published in 2010 by Jean-Mathieu Beauregard, who is our nucleus at Laval University, did compare the accuracy of conventional imaging, such as CT and bone scan, with that of fluorocholine and also FDG PET-CT. They use an heterogeneous group of patients being staged for the first time or restaged after a relapse of local therapies. And they looked if the different staging procedures were accurate in identifying a metastasis. So what they found by looking at the conventional imaging, which are CT, as I said, and bone scan, is that there were only 13% of patients that had metastasis identified by these modalities. When they used the fluorocholine, which is very good in prostate cancer for identifying lymph node and bone metastasis, they found a detection rate of 69%. But they were really surprised of finding that the FDG PET-CT was as good in this subset of patients. When they looked also at the detection rate per patient, FDG PET-CT and choline had the same detection rate in the prostate and lymph nodes, and almost the same within metastasis, which suggested that for aggressive high-grade prostate cancer, FDG may be better than initially expected or evaluated. There are also some biological data that shows that the glucose transporter, GLUT1 mRNA, is more expressed in high-grade prostate cancer. And there is also one study that did show that another GLUT transporter, the GLUT12, was found in malignant tumor but was not found in benign tumor. But this was a very small series. Only 3 patients were evaluated in each group. So what we did first is just looked at our database and also in our tissue microarray, and we'll look at the expression first of the glucose transporters in prostate cancers compared to BPH or normal prostatic glands. So we evaluated 24 patients with prostate cancer compared to 24 BPH or normal prostatic gland by immunohistochemistry with an antibody against GLUT12, and then scored each sample, and we found a significantly statistically a different expression pattern for GLUT12 in cancer. As you can see here, the staining is pretty clear in prostate cancer, and there's no staining at all in the BPH patient. Then we repeated the same approach, doing immunohistochemistry against the exokinase, which is the kinase that keeps the FDG within the cell, and we compared the normal prostatic glands with that of prostate cancer, and again, after scoring, we observed a statistically different expression pattern between benign and carcinomas. So our hypothesis based on the new studies, the one by Beauregard and also our expression pattern, was that FDG uptake might be higher in biologically high-risk prostate cancer, which we define as Gleason 8 and above. So to answer this question, we evaluated the accuracy of FDG PET-CT for biological high-risk prostate cancer staging. So between July 2011 and July 2012, 54 patients with biopsy-proven prostate cancer with Gleason above 7 at biopsy underwent an FDG PET-CT and a bone scan, and then they had the best standard of care treatment based on the findings. This generated 41 patients who underwent a radical prostatectomy and extended lymph node dissection, and 13 patients who underwent a radiation therapy or androgen deprivation therapy alone if they were metastatic. And then we compared the detection rate by FDG PET-CT with that of the pathological data of the patient who underwent surgery, and just reported the detection rate of the patient who did not undergo any surgery. So this is the cohort of our patients. This is a very high-risk patient. The clinical stage was pretty high, being T3 and T4 in 30% of patients. The PSA before biopsy was on average 16, and the Gleason sum, as I stated, was mainly Gleason 8 and 9. So looking now at the detection rate provided by the FDG PET-CT, when we take the whole cohort of 54 patients, we observed that 48% of the patient did have uptake into the prostate, while 17% of patients had uptake into the lymph nodes, and 6% had uptake into the bones. And these 3 patients that had uptake into the bone had also a positive bone scan after reimaging. This is an example of a patient that has FDG uptake within the 3 compartment. He had a Gleason 9, 5+4 prostate cancer with a CT4A clinical stage and a PSA 24. So we can see here the nice uptake within the lymph node, also the bone metastasis in the pubic symphysis, and also a nice uptake in the prostate. So this is the typical patient that had uptake in many compartments. So then we looked also at the detection rate of the patient from the radical prostatectomy group, which included 41 patients. 39% of patients had uptake into the prostate, 7% had uptake into the lymph nodes, and obviously none had any metastasis detected at the PET-CT. So once the detection rate was reported, we wanted to correlate if the FDG uptake was a predictor of any of the pathological data. So we looked at, compared the FDG uptake with the pathology obtained from our patient at radical prostatectomy. And these are the basic characteristics of the patient. So again, Gleason 8 and 9 were the patient included in this group. 82% of the patient had Gleason 8 prostate cancer. They were, again, a very high-risk prostate cancer. 50% of the patient had PT3 tumors, and 3% had a PT4. 27% of our patient had lymph node metastasis at extended lymph node dissection. On average, 18 lymph nodes were retrieved for the analysis. And when we look at the local extension, again, we see that it is a locally advanced group of patients with perineural invasion in 52.8%, vesical seminal invasion in about 30%, and extracapsular extension in 42.9% of patients. Then we compared the pathology obtained from lymph node dissection with the FDG uptake within the lymph node of our PET-CT, and we observed the sensitivity for lymph node detection of 27% and a high specificity of 100%. So all the patients that had a positive lymph node on PET-CT had also had really a metastasis. What is important to mention is that there were 7 patients that were not operated in our cohort that had positive lymph node, and of these 7, 4 had a PET-CT before and after androgen deprivation therapy. And all of those that had a controlled CT 3 months after androgen deprivation therapy did have a significant decrease in the uptake, suggesting that those were true positive. For the 3 remaining, we don't have any confirmatory study or pathology to ascertain that they were real prostate cancer. So we next compare the pathological factor associated with lymph node positivity on FDG PET-CT with our radical prostatectomy cohort. So we identified that lymph node positivity at PET scan was associated with increased PSA, increased pathological stage, pathological lymph node at surgery, and also seminal vesical invasion. And for the oncologist, the clinician, this is all features of very aggressive prostate cancer. In other words, patient that had positive lymph node had very aggressive prostate cancer. We also looked at the factors associated with prostate at that time, FDG uptake on FDG PET-CT, again in the radical prostatectomy group. And we observed that clinical stage, pathological Gleason sum, pathological Gleason pattern, the percentage of intraprostatic cancer, and the perineural invasion were all associated with an increased uptake of FDG within the prostate. Then we looked at as the ability of having an increase in intraprostatic FDG uptake to predict the presence of lymph node metastasis at radical prostatectomy. So, in other words, is there a difference between patients that had negative FDG uptake in the prostate compared to those that did not have, compared to those that had positive FDG uptake in the prostate in terms of lymph node metastasis? And the answer is yes. So in patients which had no uptake in the FDG within the prostate, only 20% of these patients had lymph node metastasis, while for those that had FDG uptake in the prostate, 40% of the patients had lymph node metastasis. However, because the small size of our cohort, we did not find it to be statistically significant. We next looked if the intraprostatic FDG uptake was a predictor of Gleason score at radical prostatectomy pathology. For those that are not used to that in the clinic, we do a biopsy first. We assign the Gleason sum to the pathology, and at prostatectomy, in about 30% of cases, the prostate cancer can be downstaged to a less aggressive prostate cancer. So the question was that, was there a difference between biopsy Gleason score and that at prostatectomy? And what we found is that the patient that had negative PET into the prostate at prostatectomy, only 30% of them had Gleason 8 or more at final pathology. However, for the patient that had a positive FDG within the prostate, 81.8% of these patients had really high-grade prostate cancer at final pathology, and this was highly significant. So FDG positivity was again a predictor of the final pathology Gleason score. We next looked if the intraprostatic FDG uptake was a predictor of Gleason pattern on radical pathology, on radical prostatectomy pathology. So again, what we show is that a patient that has a negative PET within the prostate has no chance of having here, based on our series, Gleason 9 prostate cancer. None of the one we had in our series did not have uptake in the prostate. Similarly, for those that had a positive PET scan within the prostate, none of them had Gleason pattern 3 as the main pattern within the prostate. So the probability of being downstaged to Gleason 3 plus something pattern when you have a PET positive intraprostatic FDG uptake is very low. And again, we show that the patients in the PET positive intraprostatic PET positive group that they all had either Gleason pattern 4 or 5 as the main Gleason pattern within their pathology. So in conclusion, we describe here that GLUT12 and X2 are overexpressed in prostate cancer when compared to benign glands. We also show that the FDG TEP-CT can detect prostate cancer and lymph node metastasis in a significant number of patients staged for biological high-risk prostate cancer, respectively 48% for prostates and 17% for lymph node metastasis. We also show that the FDG TEP was able to detect every bone metastasis detected by a bone scan. We also show that the intraprostatic FDG uptake is associated with a poor prognostic feature at a final pathology. However, we will need to do a clinical follow-up to see if FDG TEP-CT within the prostate has a prognostic role. And also we show that the absence of intraprostatic FDG uptake in high-risk prostate patient is associated with a high probability of pathological downstaging to intermediary risk of prostate cancer. So I would like finally to acknowledge the contributors to this study, the Canadian Urological Oncology Group, a grant program, also the Prostate Cancer Foundation Canada and Movember, and the Fonds de la Recherche en Santé du Québec. I would like also to acknowledge our nucleus, Jean-Mathieu Beauregard, who helped me to design the study, and also residents from the Laval University urology program, as well as the other urologic oncologists from Laval University that included patients in this study. Thank you.
So one of the controversies is in the management of high-risk prostate cancer patients in terms of which men should be selected for surgery versus treatment with, say, radiation and hormone therapy. And so your data suggests that FDG PET might be helpful in sort of picking out the really bad actors who might not be the best candidates for surgery, and might help sort of break that tie, so to speak, if you're trying to decide for some of these men who are on the edge. I just wonder if you see it, FDG PET as being good enough for that sort of purpose, or is it, or we still need more data to support that?
Yeah, I think that the clinical translation of these results are mainly with the FDG. From what we have now, the pathological features are so bad that we might identify very bad actors and patients that will fail very early to surgery or radiation therapy, and maybe some patient for which we might consider not exposing them to the morbidity of certain treatments. This is one of the aspects that we will have to look at with the follow-up studies. As for the clinical translation, again, the lymph node positivity will be interesting to look at because in the surgical field, there is a debate if we can have a curative aspect when we perform a lymph node dissection for positive lymph node. With such a specificity, we know that it seems that when you have a positive lymph node, there is cancer there. So you might be able to identify some patient that should not undergo surgery and maybe undergo androgen deprivation therapy plus radiation therapy if you don't believe that this patient will be cured by the lymphadenectomy. And for those patients that were operated on, it will be interesting to see how curative was the lymph node dissection. So in that aspect, I think it can differentiate maybe a patient that should undergo radiation plus androgen deprivation therapy and radical prostatectomy. The other aspect that might be more interesting for radiation therapy is I would say the length of hormonal deprivation treatment. For intermediary risk patient, you give, I don't know if you do it in London, but some people would give like 6 months of androgen deprivation therapy, and they would give 3 years for high-risk prostate cancer. So if you have, let's say, a high-risk prostate cancer, Gleason 8, at a biopsy and you have a negative PET scan, would this patient would need only 6 months of androgen deprivation therapy because they have high chance to be downstage to intermediary risk at final pathology. And this is another aspect that would be interesting to look at in future studies.
What was wrong in the previous publications that claimed that PET is not useful for prostate cancer?
What was
wrong in the previous publications?
Yeah, I was very impressed when I first looked at that, how very scant was the data telling that it was not. I think that the main problem in these studies is that they use low-grade, intermediary grade, and high-grade prostate cancer, and they put all the patient at different stage into the same pool and then said that it could not detect. We're not expecting that FDG would detect any metastasis in the lymph node in Gleason 6 prostate cancer. First, those cancers do not metastasize to lymph nodes, so there's the chance of finding a metastasis is very low. So that was one of the problems. Heterogeneous population, very small sample, and also the absence of pathological confirmation. So they just report the detection rate and then said it could or not detect, but it was very difficult I would say, to come with clear conclusions in the initial studies. That's why I decided to maybe look if there could be a potential role for FDG PET. And also something that just, I imaged a couple of patients with metastasis initially before starting this study, and all of them were positive for FDG PET CT. So that was a sort of link that led me to raise the hypothesis that high-grade prostate cancer, aggressive ones, could uptake FDG more than expected.
Thank you very much.
Thank you.